Thanks so much for joining us today. I'm Catherine Hendy, one of the founders of ELANZA Wellness, and today we're going to be looking at what to expect from each stage of the egg freezing process. And for that, I'm really delighted to be joined by Dr. Aimee, who's a fertility specialist in practice in San Ramon in California. So Dr. Aimee, thank you so much for joining us.
Thank you, Catherine. It's truly my pleasure. Thanks for having me on today.
So we're going to be covering what you can expect practically and emotionally from each step of the egg freezing journey. So as well as Dr. Aimee's clinical insights, I've personally had my eggs frozen, so I'll chime in with a few patient perspectives too. Dr. Aimee, if we can begin with just what the egg freezing process actually involves in a nutshell.
In a nutshell, the beginning process is basically exploration, learning more about your fertility, gathering information about yourself, for example, your AMH, your AFC, which is antral follicle count, your FSH, estradiol, combined with your age, and then talking to a fertility doctor to build what I call a pyramid. That pyramid allows you then to understand more about your body, how many eggs that you might achieve from one cycle, and then with your doctor's help, you'll talk about how that can help you with your family size goals in the future. The actual process involves taking injections. They're basically hormone shots every single night for approximately 10 nights or so. Every protocol is different. So you have to talk to your doctor about why they're using the protocol that they're using, what the medications are meant to achieve, the side effects, the risks. Very important to know that up front, so you feel like an empowered patient and that you are in control of something, unfortunately, is a lot that's out of our control because we can't control the number of eggs that you're going to get or the health of the eggs, but you can control the information you receive. And it's very important that you understand it and that you're educated. After you go through a series of injections, approximately every clinic will have you come in anywhere from like 3 to 5 times from start to finish. During each of these appointments, I call it the sparkle checklist. You'll find out the size of the follicles, the protocol that you're going to follow from there. Are you happy with what you're seeing, when the retrieval is going to be? Are you going to keep going? You also look at the lining of the uterus and your estrogen levels. So that all spells the word sparkle, just so you remember. And then the egg retrieval day is basically like an ultrasound while you're asleep. It sounds really scary because most people who go through egg freezing, as you know, Catherine, a lot of them have never been to the doctor before. Most haven't even had a surgery. So the time when you say surgery and then anesthesia, people start getting really scared. Their heart starts to race. They get really worried that something's going to happen. The reality is it's just like a blood draw through your ovary. Small needle, one vaginal puncture site, one on each side. And then most clinics use a combination of propofol and a drug called fentanyl, just so you can have a nice deep nap. You wake up right afterwards every single time. And you find out how many eggs were retrieved. And then later on, you'll find out how many were mature. And then after the fact, I really focus with my patients on post-egg retrieval recovery, because I don't think people realize that that is where you're going to feel the most discomfort, the most emotional. You have the worst PMS possibly of your life, and then your period starts. And that period is what I describe as a waterfall, so you're prepared for everything. And I'm so glad to be here because you can tell that I can talk about this for hours and days.
Yeah, I can, which is lucky because I'm sure our audience have plenty of questions about it. So it sounds like there's several distinct stages to the process. So perhaps we start at the first one and go into a bit more detail there. You spoke about the tests that people must have run. So what's the best place to start with that, and what sorts of tests should people be looking at getting?
Right. So once your period starts, and for some people that might not be possible because you have an IUD in place or you have some sort of implant like Nexplanon, for example. In those kinds of cases, you would want to do a test called AMH, which stands for anti-Mullerian hormone level. You can do it randomly. It doesn't matter when you're doing it. If you're someone who's on birth control pills, typically, if you are able to get that test done toward the end of the placebo week with your FSH estradiol levels, that would be the most accurate time to do it. Otherwise, if you're not taking birth control pills, 2 days after your period starts, which is basically cycle day 3, whether you're bleeding or not, we arbitrarily call it day 3, but if day 3 is a day where you can't go in, don't worry, you can do it day 1 through 4, and that's when we get the AMH, FSH, and estradiol levels. And these levels are kind of like a snapshot. They just give us an idea about the potential health of your eggs, but unfortunately, there's no perfect test. The best test is actually when you turn an egg into an embryo. But we can use these data points to then give a patient an idea as far as her pregnancy rate for the eggs that she's going to freeze at the age that she's at.
And so that's really a blood draw, which is just kind of like a standard hormone test. Something that I kind of struggled with a bit when I was at that stage in the process was, where should I get that done? Is it something that I do at my primary care provider, my OBGYN, a fertility clinic? Could I use an at-home test?
Yeah, I mean, with the pandemic, there are a lot of fears about going into labs, going into doctors' offices, which I can totally understand. So you can always start with an at-home test. But, for my patients, I use Quest and LabCorp, which are national labs with sites in every single state. And I send a lab slip to the patient so she can print it out, take it in with her. I also fax it directly to the lab. So if there's an issue there, with a fax or something like that, she has it in her hand and then she'll go into the lab for that test. And we also draw in the office as well. Most clinics that are fertility clinics will draw in the office. Most OBGYNs will refer you to a clinic, a lab, but you just have to ask and then you'll find out whether your OBGYN or your primary care doctor will do it for you. Many will, but some don't feel comfortable doing it because they're not comfortable analyzing and interpreting the results for you.
So when I went in to a fertility clinic actually and they ran those hormone blood tests, they also did something else, which was an ultrasound of my ovaries. Is that what you consider part of that initial test as well?
Absolutely. So, with COVID, we are doing most of our consults virtually. And then once I talk to a patient, have her labs drawn, then I'll bring her in for a pre-egg freezing ultrasound. And during that ultrasound, I'm actually looking at the AMH and asking myself the question, does the antral count, does this all add up? Or is there something that just doesn't add up? For example, if you have an AMH of 2 and you only see like 4 follicles, you would say there's something that's just not quite right. Is it that the AMH should be redrawn? Or is it that this just isn't a good cycle for us and we should wait, maybe see if we can get the egg count a little bit higher? But the AFC, or antral follicle count, is a very important ultrasound where you can learn a lot about the potential number of eggs that you can have retrieved during an egg freezing cycle.
When you're reading those test results, so particularly when you're looking at the blood hormone levels, is there a particular level at which you would say someone can or can't do egg freezing?
Yeah, I mean, I think that sometimes we hear things about ourselves that may not be true and factual. I'll give you an example. So let's say you're 25 years old and your AMH level is 0.6. You might be told you have the hormone levels of a 40-year-old, right? Like those things that's just not correct messaging. At 25, if your AMH, let's say is 0.6, you truly have the eggs of a 25-year-old, and it's very worthwhile freezing because those eggs probably are still genetically normal because they've been around for 25 years, not 40 or 45. Then on the other side of things, if you're 40 years old, let's say with an AMH of 0.6, what you have to realize is if you're exploring egg freezing at that point in your life, you have to say, I may not be freezing eggs that will give me a chance for pregnancy, because it's really hard to find a good egg, no matter what your hormone levels are. But at the same time, I have had so many successful egg freezing stories from women who decide to freeze over the age of 37. So I still think it's really important for women who are over 35 to realize that egg freezing can also be for them too.
And it might just be something where somebody's thinking instead of doing one cycle, maybe they would do multiple. And maybe this testing phase is where you'd be able to help them figure out that path.
And that's right. Not only in the testing phase, but after I freeze the eggs as well, I look at the quality because I literally get a description of the eggs from the embryology lab. I revisit my patient's goals as far as how many kids she wants and when. And then I make my guidance based on one thing, and that is I want all my patients to have at least a 50% chance of having 2 kids from the eggs that they have frozen, not just 1. And so there are a lot of really good resources out there, and egg calculators basically that you just put in your age, the number of mature eggs, and it tells you what the percentage rate of pregnancy would be for you for 1, 2, or 3 kids. So I use that tool to show my patients, I give it to them, and I say, play around with this. So you understand what it means if you do another cycle now, if you wait 2 years and you do another cycle then. And I always try and encourage people to try and create embryos out of their eggs at a time when they still could have healthy eggs left. So you don't feel like heartbroken and upset that you didn't freeze enough when you still had eggs left.
Yeah, that's a really, really good point. And once you've had the test results back and you've discussed them with the reproductive endocrinologist, what's the next step then?
So the next step was to make your calendar for you. And I tell my patients to find a really good time in your life where you can come and go to a fertility clinic without a lot of stress, and then also have time to relax at home after the egg retrieval so you can have a really smooth recovery.
Yeah, totally. And then is there anything, before you actually begin the cycle then that you might want to do in order to prepare yourself? I mean, how quickly can it actually happen?
Absolutely. So at my first visit with my patients, and you guys have a great guide as well that I share with my patients as far as like eating healthy, avoiding marijuana, just being the best version of yourself. And I also recommend taking supplements. And for most of my patients, I ask them to take something called CoQ10. And I ask my patients to take it until they're done having kids, because and it might help improve egg quality over time.
Yeah, I actually, before I did my egg freezing cycle a few years ago, which is, before we really got deep into the research on this, before we wrote the book, Everything Egg Freezing, and started ELANZA Wellness, I didn't actually make any lifestyle changes or, kind of look into preparing myself, even in a short window before my egg freezing cycle. And I really wish that I'd just taken a little bit of time to do that, because even if physically, there's not much that you can tweak, I do think it helps you prepare emotionally as well to feel like you've got yourself in the best position. So some clinics put people on a birth control protocol before they freeze their eggs. Could you talk a little bit about that?
Yeah, I mean, it sounds counterintuitive. Wait, I'm doing a treatment and you're putting me on birth control? But the way I think of it is this: birth control pills are also egg freezing preparedness pills. That's it. They allow us to plan your cycle ahead of time so you can kind of see what your life will look like and actually confirm your appointments way in advance. However, there are some patients that I don't like to use birth control pills for. Those are my older patients with less eggs. I find that it can reduce the number of mature eggs that I could possibly get from that patient. But some clinics, they have to use birth control pills for all their patients because they don't do IVF 7 days a week the way I do. So you have to ask, why are you using this protocol? How is this going to affect me? Would I be better off without them? And if the explanation is a good one, like we're trying to, plan your cycles so that it's coordinated and you're not overwhelmed and we have time to teach you, order your medications, make your appointments, and that's fine with you, that's great. Otherwise, if you're someone who's super sensitive to the birth control pill, you don't have to take it.
That's good to know, really good to know. And then when it comes time to actually start the bulk, the main bit of the procedure itself, how does that begin? How do you know when it's time to start?
Well, if you're doing a natural cycle start, typically it starts the day after your period. So I tell my patients, if your period starts, think of me and come on in by cycle day 3, right? It rhymes, it's easy to remember. So patients will come in, I'll teach them how to do everything. We do one-on-one training here. For patients who are very nervous, we actually do injections in the office as well. We'll even mix for medication. So whatever we need to do to make it happen for the patient so she can get through the cycle without, much disturbance in her life, we will do it. And then at that point, we plan her calendar and when she comes in, and we teach her the protocol and exactly what she's going to do and when. And I'm always guiding patients about how they're going to feel along the way. Because in the beginning, as you know, you might feel a little nauseous, have headaches, you're on your period. And sometimes people think that if they take a Tylenol or they use a tampon, like those kinds of things can interfere with the cycle. But I always reassure people that I don't want you to tough anything out, and take pain meds if you have it. If you start to feel nauseous, tell me, because I can always order you an anti-nausea pill so that you don't suffer greatly. There's no need to suffer or power through any of this. We want the experience to be easy peasy.
Yeah, I have to say, I thought that the injections were going to be worse than they were in terms of actually administering the injection to myself. The needle was really fine. I think someone said that it's kind of like the needles that diabetic kids would inject their insulin with, which kind of made me feel a bit better. I was like, okay, well, if little kids are doing this, then I really should be able to do it. So that kind of helped. You mentioned before, it's a kind of 10 to 14 day window, depending on the individual. After a few days, you do start to notice some side effects, don't you, from those hormones?
Yeah, so some patients start to feel twinges in their ovaries. They also start to see the same thing you see around ovulation time, which is how your body reacts to a rising estrogen. And that's egg white cervical mucus, maybe some nipple tenderness. But doesn't mean you're ovulating, because we also administer medications to prevent you from ovulating. But sometimes people call the clinic freaking out, like, oh my God, I'm ovulating, but not my patients, because I already have told them in advance. And then the bloating, the swelling, There is water weight gain typically for everybody, at least 2 pounds. For some people, it can even be 7 pounds. And then a lot of people are worried actually because they actually feel really good up until the egg retrieval. And they're like, is something wrong with me? But that can be okay. I mean, the reason why we tell people about all the possible side effects is so you don't feel like there's some sort of complication from the treatment and this kind of stuff is normal. You can also get an injection site reaction, maybe some bruising at the site of the injection. Some people get a little bit itchy. So I tell my patients to make sure they have some Benadryl cream at home. That trigger shot can sometimes be more itchy or itchier than the other shots. And then after the egg retrieval, you might see some spotting. You might have a harder time moving around. You might want to just be in your comfy jammies with your fuzzy slippers for a couple days after the egg retrieval.
Yeah, 100%. And kind of during this stage, patients will need to come into the clinic regularly. Maybe that's a little bit different during COVID, but usually you need to go in every few days.
That's right. So start of your period, then maybe 4 to 5 days later, 2 days after that, 2 days after that, and then it's the egg retrieval. So it's about 5 times from the start until the egg retrieval.
And what's happening during those visits?
That's when we go through the sparkle checklist, right? So we take a look at the ovaries, the lining, the uterus. We're doing a blood draw, and we're communicating with the patient about, are we happy? Are we going to keep going? And what are you going to do from here?
So during that time, you might be tweaking medications up or down. Why might that be? And what's the purpose there?
Yeah, the goal is to achieve the highest number of mature eggs in the safest way possible. So by adjusting medications, sometimes we can accomplish that. We learn a lot about how someone responds to medication by actually going through it. There isn't like a guide like, oh, you put in something into a computer and you say exactly how much medications the patient's going to use. So that's why we have to do these ultrasounds, because the size of the follicles will grow as the cycle continues. And we rely on the size along with the estrogen level to tell us when the best day would be to actually do the egg harvesting. So that's the reason behind it. And we add in medications to prevent ovulation, for example. We sometimes add medications that help with egg quality like HGH. And then we do the last shot, which is the trigger shot, which is approximately 36 hours before the egg retrieval.
So it sounds like it's kind of as unique as our own menstrual cycles. And some people, get really bad premenstrual symptoms. Other people don't. And, it's unique to the individual. But I know that although broadly, most people's side effects are quite manageable, in some cases, you can actually develop quite risky side effects. Could you talk a bit about that, what people might want to watch out for?
Right. So young women with a high AMH level and a very high follicle count are at risk of something called severe OHSS, ovarian hyperstimulation syndrome. So I have my, ways to prevent it. And that would be starting at a lower dose after 2 days of shots, coming in for a blood draw. And I don't tell my patients what to do until I get their estrogen level back. And then I titrate the dose accordingly. And I see patients like that a little bit more frequently. So they may get 1 or 2 extra visits that someone who doesn't have that high count would get. And then there are certain medications that we try and avoid in cases like that. That would be HCG as a trigger shot. We like to use another medication called Lupron. And then I also talk to my patients about salty drinks or electrolyte-rich drinks like Gatorade, G2, Propel, protein bars and shakes, whey protein especially. You can also consume plant-based protein. I tell my patients to start at 20 grams per day, usually around treatment day 4 or 5, and then go up to 40, 60, even 80 after the egg retrieval for a few days, as that has been shown to prevent severe OHSS. And there are a couple other drugs that we can also use, like Femara and bromocriptine, after the trigger shot to also help prevent that from happening. So it's super important when you're young and you have a lot of eggs to make sure that you are asking your doctor, what are you going to do to prevent severe OHSS? What are the emergency numbers for the clinic? What can I expect? When should I be worried? When should I call? So my patients don't have to say that because I'm already telling them ahead of time, but I know not everyone gives patients these checklists and tells them the things to look out for. So important for you to ask your doctor what those things are if you haven't already.
So pretty rare, but for certain groups of patients, definitely something that they should be bringing up and making sure that they feel okay about.
Yeah, I mean, it's uncommon, especially nowadays. Fertility doctors now know how to deal with it and the warning signs and when to use Lupron as a trigger shot, when not to. So I think we all generally do a really good job preventing severe OHSS.
And we come to the retrieval itself, so getting those eggs out of the ovaries. How do you know when the right time is for the retrieval?
Yeah, so we basically look at the size of the follicles and they tell us. So once the follicle is over, typically around 18 millimeters in size or above, we know that reliably the egg inside should be mature. That's the hardest part of being an egg freezing patient. Sometimes you learn that your eggs aren't as viable as everything was demonstrating along the way. You know what I mean? Like you could expect, 15 mature eggs and have only gotten 8. And that can be soul crushing because you feel like now something's wrong with you. Like you did something that was elective and now you're finding out that there might be something wrong. And you're like, why did I even do this? But that's why I have basically a checklist of things that I ask my patients to talk to themselves about. And one of the things so they're prepared for it, is how would you feel if you did egg freezing and then found out that you actually had a fertility problem, right? Like what if there was something abnormal about your eggs that they saw? How would that make you feel? And so you have to have that conversation ahead of time. The likelihood of that happening is usually in a young woman very low, but it could still happen.
Yeah, I think that just being prepared to feel quite tense, right before the retrieval is probably is just something to be aware of. I felt quite calm during the actual hormone injection cycle itself. But on the morning of, I woke up with really, really severe bloating. I felt so fed up. And I think I also just felt a bit scared. This is the big moment that everything that you've paid for and that you're pinning your hopes on has come. So just making sure that you've got the right support in place and making sure that you're, being kind to yourself and, meditating or doing whatever gets you into a great headspace around about the retrieval, I think is wise to prepare. Mm-hmm. So now that we've come to the actual procedure, what happens in the operational? We're not calling it an operation. What happens in the procedure? Yeah,
so you're actually going into a room that looks like an operating room in most clinics, and it's attached to the IVF lab. And you're basically, lying down and getting an ultrasound while you're asleep. So anesthesiologist is watching over you while the doctor's placing a probe in the vagina, and we use an ultrasound that has a needle guide on it, and then we just, place a very small needle through the walls of the vagina, and we basically aspirate the fluid from each follicle, taking out an egg. And then the embryologist is looking through the fluid that they're being handed, and then they're going to tell us how many eggs you have. And then they go through a special processing system of called egg stripping. It sounds very scandalous. And they strip the eggs. They basically remove this cloud of cells called the cumulus cells from around the egg. And then they tell us how many are mature. And those are the eggs that get frozen for you, because only mature eggs can be used in the future and be fertilized by sperm.
And is there any such thing as an average number of eggs that people retrieve at a particular age, say 30, 35, 40?
I mean, the thing is that your number is your number. And I feel like sometimes this stuff kind of turns into a competition between people. And I don't think that's fair. And I feel like, I can have a 25-year-old that has 6 eggs that could be great. And then I can have a 34-year-old that has 15 eggs, but the 25-year-old's eggs are going to be better, so, as far as like average numbers, I like to focus on the patient's individual numbers, like her numbers, and focus on that rather than comparing her to anybody else.
And so once the eggs have been through that preparation process, then they're actually frozen. And does that happen in the clinic itself?
Yeah, they get flash frozen, and that's called vitrification in the IVF lab. And then most labs nowadays will actually, for egg freezing patients who aren't planning on using their eggs anytime soon, will transfer them to long-term storage facilities. And then when the patient's ready to use them, they get shipped back to the clinic or the clinic of their choice for them to use at that point.
And so how long does it take to recover after the retrieval once you come around from that sedative?
So what I tell patients is you're going to feel pretty sleepy that day, and you're probably not going to want to do much but, get in your comfy jammies and wear your fuzzy slippers. And then the next day, 95% of my patients will go back to work. But my patients who have over 15 eggs retrieved, they're usually really happy to have some flexibility and be able to stay home. But the rest of the time, most patients can resume their normal life, aside from things like, heavy lifting, high impact, high intensity exercise and pelvic intercourse. Everything else usually is pretty much the same.
Full disclosure, I took an international flight the day after mine, which probably wasn't very clever. I'm sure that there are things that you put on that try not to do list.
Right. Yes. I mean, you can feel quite uncomfortable the day after.
And is there anything that people might be able to do to help speed up that recovery process, kind of flush out those excess hormones?
Absolutely. I mean, that's why I focus on all the things that I shared, like the electrolyte-rich drinks, hydrating with salty water is what I call it, basically.
Yeah.
And protein-rich powders, the powdered drinks can really help. And you just keep up with it, and the passage of time will help. Using a heating pad and taking pain meds and staying on top of it, and then using a stool softener. I don't think people talk enough about how difficult it can be to have a bowel movement after you've had anesthesia and swollen ovaries. So using a stool softener is also something that can be really helpful to help with the bloating as well.
Great tip. And then finally, I think there's a stage that can be overlooked, which is, after the retrieval, after the recovery, kind of reflecting on the cycle and thinking, okay, I've done that now. Does that still fit with my goals? The number of eggs that I got, kind of that post-retrieval counseling. What are some things that people might want to think about at that stage?
Yeah, I mean, I would recommend that you get all the official reports and make a post-egg freezing consult with your doctor and revisit your goals with them. And those goals are, what do I want? What is it going to take to get it? And am I willing to do it? And you can't have someone help you with answering those questions unless you tell them what you want and what your goals are. You have to make sure that your priorities are your doctor's, because sometimes, you might have these priorities and the doctor might think that that's just too much and you don't need to do that. But truly, these are your goals, and, indefinitely, everyone's eggs will run out. And if you're someone who will choose to, use your eggs maybe in 5 years at a time where you will have a lower likelihood of getting pregnant naturally, you should advocate for yourself and do more if that's something that you really want to do. But also you want to make sure that you're getting honesty and transparency from the clinic and look at the reports yourself and ask, how did my eggs look? Were there any comments about them as far as, being less quality than what we assume? And what's the chance for me to have 1 baby, 2, and 3 from this batch of eggs? And then you can decide whether you would do another cycle, what you learned from the cycle, what you would do differently.
At the end of all of this, there's no particular time limit for using the frozen eggs. So the kind of final stage, I suppose, actually really is coming back to use them if that's something that you need to do in the future. But you don't have to use them within a certain time frame.
That's right. There's no such thing as freezer burn. You can use them indefinitely. So there should be no pressure to use them. And sometimes people are confused by the whole, well, what if I don't have periods anymore? Then I probably can't use them. And it's no, we use hormones to mimic ovulation and mimic your cycle. So when you're ready to use them, whatever is going on with your ovaries, whether you're for example, in menopause or not, it doesn't matter. We can still use those eggs and help you get pregnant as long as you have a healthy uterus and you're healthy as well.
Thank you so much for being here with us today. That was really illuminating, and you've got some great tips and some great points in there that I think, even as someone who's frozen my eggs in the past, were really good to hear. So thank you so much for that.
Thank you, Catherine, for having me.